is infections, and unfortunately being anesthetists now, we don't have a key of understanding all these things. It's not a problem, it's a problem of the way we have studied. During anesthesia days, we haven't really gone ahead and actually looked at all these parts, which are very important for us. When you come to intensive care, it's a completely different ballgame when we think of intensive care. Okay, so one by one, let us go to what this all is about. So initially, the first penicillin which was discovered, she started by talking about history. So penicillin was discovered somewhere in 1940s. 1940s, the very next year after penicillin was discovered. The very next year the penicillin was discovered, penicillin became resistant. The very next year. Okay, so they developed a couple of antibiotics after that to combat that kind of resistance. It was in the early 1960s that methicillin came in, and then methicillin resistance started. Are you understanding? Methicillin resistance started. Now, that's why it is called as MRSA. When methicillin is an outdated antibiotic, it's no longer there now. Okay? So MRSA, okay, that's how MRSA comes in. MRSA. Now MRSA, when you say MRSA, there has to be MSSA also. Okay, so there is methicillin resistant Staphylococcus aureus and there is methicillin sensitive Staphylococcus aureus. Both of them being Staphylococcus aureus. The differentiating factor between both of them, as the name suggests, is that this is more resistant. As the name says, this is more resistant. And when you say resistance, how does it develop resistance? So if there were 4 mechanisms of resistance, what are the few mechanisms of resistance that you know? That it has got beta-lactamase hydrolyzing enzyme, which, what's your name? Gokul was talking, beta-lactamase hydrolyzing. Second is efflux pumps. Third is alteration of target binding sites. Okay, these are few mechanisms of resistance of any bacteria. It could be either hydrolyzing enzymes, it could be either they are unable to get inside only, or if they are going inside, they are coming outside. These are some of the very common resistance mechanisms that you have. So if somebody asks you which resistance mechanism out of these are the ones that actually MRSA becomes resistant, it is usually alteration of target binding site. Now, normally how these are working, you have a target binding site called as PB2A. PB2A. Now, what methicillin resistant Staphylococcus aureus has is that it's got PB2A is what we're talking about. What is happening in methicillin in these Staph aureus organisms is that they've got a gene called as MEC. MEC gene. This is MEC gene is from 1 to 4 to 5. 1 to 5. They've got genes from 1 to 5 which have make this penicillin binding protein altered. Since it makes this penicillin binding protein altered, the antibiotic can never enter inside the Staph aureus. There's alteration of target binding sites, and that's what causes MRSA to become MRSA. Okay, so the answer is, if you want to diagnose a patient of MRSA, the way you can diagnose it is by figuring out whether there is a PB2A alteration because of the MEC gene 1 to 5. This is also called as staphylococcal cassette chromosome. So chromosomal resistance mechanisms. You understand? It's got staphylococcal cassette chromosome, which is MEC gene. Okay, this MEC gene is the one which is from 1 to 5. Okay, 1 to 5, where it alters the penicillin binding protein. You understand? So whenever we talk of resistance, so this is what we're talking about, MRSA, right? We have to diagnose them. You have to diagnose this patient as MRSA. And to diagnose them as MRSA, how do you diagnose them as MRSA? To diagnose them, any organism for resistance patterns, there are 2 tests. Can you tell me which of those 2 tests? 2 basic tests that you have. 2 basic tests that you have to diagnose resistance in any organism. For example, Klebsiella, Pseudomonas, anything. There are 2 kinds of tests. Anyone? We have told this many times. So 2 types of tests. One test is called as a genotypic test, and the other is called as a phenotypic test. There are 2 tests. There are always 2 tests that will explain resistance mechanism for any organism. One is called as genotypic test, and the other is called as phenotypic tests. Clear on this? Genotypic tests and phenotypic tests. Any doubts till now? No. Alright. Now, in this case, when you say phenotypic test, means I'm going to look at something, and I'm going to say, okay, this is why it is resistant. So it's like a disc diffusion. So you have a disc inside, you put an antibiotic in a colony, and you find clearance. This diffusion is a form of phenotypic test. Okay, it's a form of phenotypic test. Are you understanding? It's a form of phenotypic. Genotypic test is when you go and look into the gene only and say, okay, this gene is there. This gene is there. You understand that this MEK gene is there. So that's called genotypic tests. So all these PCRs that you talk of are genotypic tests. That is why when you see a PCR biofire report, at the end is written, this gene is present, this gene is present, this gene is positive for VAN, this KPC, NDM, OXA. We need to do all these things. We see NDM, that's a gene. OXA, that's gene. Okay. Similarly, so that's why genotypic methodology is there and phenotypic methodology is there. Okay, so in the genotypic methodology, what will you have? PCR based techniques, which could be multiplex, uniplex, whatever. When multiplex means multiple organisms together, uni means one. Okay, so RT-PCRs is a classical example for genotypic technology. Okay, so genotypic methods to understand MRSA, right? And the other is phenotypic mechanisms. When you say phenotypic mechanisms, means I'm going to do disc diffusion. I'm going to do something called E-strip technology. You know what is E-strip? E-strip is you take the strip, put it in the agar, and it starts showing signs of how much it is, how much is the resistance mechanism. That's E-strip technology. So disc diffusion, that's DD. E-strip technology, MIC method, minimum inhibitory concentration method, where you put it in different CNC where it gets cleared off. MIC method. Then you have broth dilution method. Broad dilution method. So these are phenotypic mechanisms. These are phenotypic mechanisms that you have for detecting resistance in any organism. Okay, in any organism. So every organism will have a genotypic method and a phenotypic method. What you see as an automated method coming from there is automated. It's an automated method, that is a phenotypic method, which is automated coming from Vitek to you, saying that this bacteria is resistant to this antibiotic. That's a phenotypic method. Right, automated. That's called the Vitek 2. The machine that does it is called as Vitek 2. There are many such machines that are there. Vitek 2. Clear? So you have genotypic mechanisms and phenotypic mechanisms. Clear till now? Clear till now? Genotypic mechanisms and phenotypic mechanisms. So in MRSA, to actually diagnose them as MRSA, the commonest used mechanism is actually called the cefoxitin disc diffusion mechanism. The commonest method used is cefoxitin disc diffusion mechanism. Cefoxitin disc diffusion mechanism. They are not really testing methicillin. They are actually looking at a surrogate with this cefoxitin. You understand? That's what they are doing. Now the problem with this is that it might not do all Staph aureus. It might miss out certain Staph aureus like Staph hemolyticus, like certain Staphylococcus like hemolyticus. Staph is of various types. There is lugdunensis, there is hemolyticus, there is saprophyticus, there is so much of Staphylococcus. Cefoxitin is a disc diffusion method you use for all Staphylococci. So what will happen with that cefoxitin disc diffusion method? It can miss out organisms like Staph hemolyticus. Luckily, Staph hemolyticus, lugdunensis, saprophyticus, this is quite rare. So we don't really have much of a problem. But yes, it can miss out Staph hemolyticus. Clear? So tomorrow, if you have a patient who has Staph hemolyticus, it may not show you MRSH. You will call it as MRSH, methicillin resistant Staph hemolyticus, right? It may not show you that. Are you understanding the issue? It will not show you that. So there is a problem with cefoxitin disc diffusion, though it's the commonest. So if someone asks me what is the commonest method used in the whole country, or for that matter in the world, it is cefoxitin disc diffusion method to actually diagnose MRSA. It will miss out. It's got its own small ramifications that it has. Which is the most ideal method? Which is the most ideal method? The most ideal method is what is the? No. Ideal method is what? She had it on a slide. What is the ideal method? Did you read your slide? What is your slide? Which is the ideal method? So you must always remember. No, the ideal method is oxacillin MIC. Oxacillin MIC microbrod dilution method. This is the ideal method. Oxacillin MIC microbrod dilution method. Okay, so this is the ideal method, oxacillin MIC microbrod dilution technique. But you know, as you understand, microbrod dilution techniques are going to be cumbersome. They are going to be cumbersome because you have to make titration wells, then you have to put it, then figure out the formula, figure out which is the one. So it's a cumbersome technique. Like for example, when you ask for colistin microbrod dilution, it takes a day before they can actually give you the answer. So it's going to take time to do microbrod dilution. So it's cumbersome, laborious, and it requires specific endpoints to actually figure out how to do this. So not can be done by an average microbiologist, may not be able to do that. So this is ideal, however it is not done on a regular basis, right? Ideal. Which is the most rapid? The most rapid would be actually just detect PB2A. Just detect this phenotype PB2A. Just detect it. Just figure out where this PB2A. So that will be the fastest. Like tomorrow, when you do a lateral flow assay, it's called lateral flow assay. Not available in the country, not available in many places across the world also. In your lateral flow assay, you will get to know PB2A. That is what you want to figure out, whether a PB2A has been altered, right? So when you see this altered PB2A, you can actually figure out this is methicillin resistant. So what is commonest? Commonest is cefoxylin disc diffusion. This is what we probably do in the hospital. What is the ideal? Oxacillin MIC microbrod dilution technique. What is the most rapid? The most rapid is PB2A determination by lateral flow assay. That's the most rapid. But today I put it to, I'll get it in an hour. I know this is PB2A. You understand? Lateral flow assay. These are all phenotypic methods. Whereas, what can be also done? You can also do genotypic methods, which is PCR based. PCR based. This PCR based technology is about this. PCR based technology is there. This is some genotypic method that can be done. Right? However, as you know, PCR based technologies are expensive. PCR based technologies are expensive. So the problem is expense and it's not available everywhere. You can't have PCR technology in your hospital, very less likely. You understand? So it's expensive. So it's not there that is freely available. It's not, and we are looking at the city, that's why you are hearing PCR, PCR, PCR. But probably if you were away from the city, you would not even understand what PCR is because it's not there only. You understand? So genotypic mechanisms is the way to understand MRSA. So have you understood what MRSA is? It is called methicillin resistance because that term came in 1960s when methicillin became resistant, and then methicillin was thrown out of the window because methicillin never worked. So in place of methicillin, they started using oxacillin and cefoxytin, and that's what the surrogate markers are all about for MRSA. That's how the word MRSA comes in. Clear on this? Now, what actually happened was till 1960s, also we thought the MRSA, okay, fine, it's just MRSA, the thing. But what they found in the early 80s and 90s was, it started spreading like wildfire. Community spread came in. For example, in a group of athletes, in a group of prisoners, in a group of soldiers in the army, people were dying of MRSA, developing skin and soft tissue infection, boils, furuncles, impetigo, in tons and tons and tons. They started going to that situation. That's why it's always said that if it's a community spread, even it looks at MRSA, and that's why it's a dangerous drug. Since it's so easily communicably spread, this MRSA, it can spread very badly in the hospital. Since it can be easily spread in the community, compared to Klebsiella, Pseudomonas, there are no outbreaks of Klebsiella or Pseudomonas in a community. We've never seen that. Klebsiella, Pseudomonas, you've seen that in the community. But what happens with MRSA is there was a community spread. 1996, there was a huge spread in the whole Olympic Stadium apparently of MRSA. So soldiers, army recruits, then people who are in prisons, they spread like wildfire MRSA, and that's why it became a big concern. If the prison's full of MRSA, where will you transfer these patients? Where will you keep them? It's a very big practical problem, isn't it? So MRSA spreads in the community and it spreads very quickly, and that is the reason that MRSA is what MRSA is all about. MRSA is one of the most difficult organisms because of this reason, because it spreads like wildfire. So imagine MRSA gets into the hospital, it will spread like mad in the hospital itself. So that's what MRSA is all about. Clear? So army recruits, hospital acquired. Now you can understand why MRSA becomes more dangerous in hospital acquired infections, because it can spread like mad and it can create havoc in a patient who's already sick. Okay, so hospital acquired MRSA. So when you say MRSA, now that you've understood what MRSA is about, okay, you must remember, because of this situation of MRSA, of it being spread, easily acquired, moving from place to place, MRSA is the only MDR. Otherwise, what is the definition of MDR? What is the definition of MDR organisms? More than two classes of antibiotics. You should be actually resistant to more than two classes of antibiotics to call it as MDR. Two classes. Two classes. MRSA is one class. Methicillin. You understand? Just one class. You understand? Even though it is one class, it is still categorized as, even then it is classified as MDR. You understand? So the only organism in the literature to be classified as MDR, in spite of having only one resistance, even having only one class of antibiotics that is resistant to, is MRSA. Clear? Am I clear till now about MRSA? So I hope you've understood A. What have we done first? We've understood what MRSA is. What is MRSA? This is what you understood. You understood this now?
Yes.
The next thing that we've understood is how to diagnose MRSA. How to diagnose an MRSA in the microbiology lab. We have understood this. The third thing now we understand is what is the types of MRSA. What are the types of MRSA we know? There are certain terminologies you must know when it comes to MRSA. The first type of MRSA that we can talk about is CA-MRSA. First is HA-MRSA. When you say HA-MRSA, it means MRSA that is acquired after 48 hours of admission to the hospital. Hospital acquired MRSA is that MRSA that is acquired. You know what? I'll put this. I have this on my blog. You can just open it from the blog and see. If you go to drsanjit.com, I don't think you should write this because I think you should listen. You can just open up on the blog. If it's not there, I'll upload it. That's not a problem. You can just upload it. It's very shortly given in that. I think you should just open that. There's a section in the blog called as Fast and Furious. Okay, in the blogs, there's a section Fast and Furious. Go to Fast and Furious, you'll get the whole chapter in like one page. You understand? So go to the blog and read it too. I don't think you should write it down. Please listen. Okay, it makes more sense. So we have hospital-acquired MRSA, which actually says those organisms, when you get MRSA after 48 hours of getting admitted to the hospital. So in short, it is something that you acquire. So that is why it is called as hospital-acquired MRSA. Clear on this? Clear on this? Similarly, there is CA-MRSA, which basically means that the patient has come in with MRSA. That means he came to the hospital, you did a blood culture or you did a culture of the pus swab and there is MRSA in that. Or tissue culture, you got MRSA. That's community acquired MRSA. That's community acquired MRSA. Clear? Then there is another MRSA called as LA-MRSA. What is LA-MRSA? LA-MRSA is something that we've learned recently, which is called as livestock associated MRSA. That means the person is in a community where he is treating chickens and muttons or whatever, goats and all, and then he gets it from that. So it's livestock associated MRSA. From his occupation he's got that. So livestock associated MRSA, which is also a big burden for us because of the animal husbandry department. Okay, livestock associated MRSA. Clear on this? Livestock associated MRSA. Then you have inducible dormant MRSA. Now what is inducible dormant MRSA? For this you must now understand what we just now talked. Phenotypic and genotypic. Okay, what happens over there is that the gene is there for causing MRSA. However, it doesn't reveal. It doesn't show itself off. You understand? Phenotypic mechanisms don't show you that there is Staph aureus, that is MRSA. It just shows you Staph aureus, the phenotypic mechanism. But the gene is there inside. So you will have this report where you will do a phenotypic mechanism. It will say Staphylococcus aureus sensitive to everything. But when you do a PCR based technology, you will get positive for MRSA gene, make A gene positive. You understand? This is called as inducible dormant MRSA. At any given moment, this can be converted to MRSA. And that's why it's called inducible dormant MRSA. Clear on this? So there's inducible dormant MRSA, which is something that can convert at any given moment. The difference being there is a discrepancy between the phenotypic mechanism which we just now discussed and the genotypic mechanism that we just now discussed. Clear?
It will remain resistant to the drug.
Yeah.
Even if it is.
It can become resistant at any given moment, and I'll come to that why it's important for you to know this. Okay, it's important for you to know it's inducible dormant. That's why if you want to diagnose MRSA, we require all the tests that we have in place to understand MRSA. Okay, so to answer that question, why it's important for us is because you treat every patient initially as an MRSA. If you think that there is a suspicion for MRSA, you understand? And then you de-escalate, because we know that if you escalate and the time period being 3 days, the mortality is high. So say for example you don't treat, and 3 days later you find MRSA, and at third day you start the treatment for MRSA, the mortality is very high. Okay, whereas you have a patient over here, you started and you de-escalated, the mortality is lower. We know that, especially when it comes to staph aureus. That's why you need to escalate quickly, start empirically quickly, and then de-escalate on the later date. Right? Now, we'll go to some of these MRSA. So when you say, so let us differentiate between hospital-acquired and community-acquired MRSA. It's very important to differentiate both of them. Okay, and there is also healthcare-associated MRSA. This is another one. When you say healthcare-associated MRSA, means when the patient came, he did not have it, in less than 48 hours, you have actually found out it is not community-acquired. You found it in less than 48 hours. This is probably because of people who are from long-term care facilities, who are on dialysis lines. Now, for example, you have a patient in the ward, the patient is on a dialysis line, and then he comes to you. When he is in the dialysis unit and he comes to you. He is a long-term care facility. For example, he is in an old age home with a catheter in place. Okay, and then comes to you. Okay, and then you find out this is, or he is at home taking home parenteral nutrition. He comes to you. Okay, this is not community acquired in the real sense. This is healthcare associated MRSA. Healthcare associated. Now, some healthcare is going on to him, and that healthcare ke beech mein he has got this MRSA. So that's why this is called as healthcare associated MRSA. So now after understanding what is MRSA, we have now understood the types of MRSA. Right? We've understood the types of MRSA. Clear? We've understood types. Now let's go to understanding what is the differentiating factor between community acquired MRSA versus hospital acquired. And this is very important. This is very important not only for an exam point of view, but otherwise for even diagnosing and for treating patients. It's very important that you understand this very well. Okay, so first of all, staph aureus is definitely a prevalent organism. You must understand this. It's not that it is very less and more, or very less. I don't have to consider it. It's a prevalent organism. When I say prevalence, the prevalent rate is more than 30%. 27 to 30% is the prevalence of MRSA in the country. In our country, the prevalence is 27 to 37%. If you remember last time we did pneumonia, we said anything more than 10% is dangerous. Anything more than 10% is something that you need to cover. Anything more than 10% is your point of concern. Okay, this is 27%, 3 times what your point of concern is. Okay, 3 times what your point of concern is. And if you get MRSA and you get bacteremia and you don't treat it early, the mortality is more upwards of 60 to 70%. If you get septic shock, mortality is 60 to 70%. Not only is that, this is the problem, it's also a situation that Staphylococcus aureus is such an organism that can go and get stuck anywhere. That's another problem with Staphylococcus aureus. You can go and get stuck to your heart valves, you can go and get stuck to your pacemaker, you can go and get stuck to your central line if it's not been treated adequately. So problem with staph is this, that it can just go and seed everywhere. Okay. So that's why you need to understand MRSA, and the differentiating factor between community acquired and hospital acquired MRSA is also very important. The profile of a patient who is actually community acquired MRSA would be a young patient, maybe an army recruit, maybe a person who is living in a crowded environment, maybe a person who is actually an athlete in a group of going together from place to place, like a group of kabaddi players. So this is usually the characteristic of community acquired MRSA. Community acquired MRSA, that would be the characteristic. Young patients, okay. Whereas when you say hospital acquired MRSA, we're looking at those patients who have comorbidities, who are old, who have indwelling lines, who have got dialysis going on, who have got pacemakers in place. These are the hospital acquired MRSAs. The patient profile is slightly different from community acquired and hospital acquired MRSA. The other thing about the patient profile or patient symptoms are that these patients usually would present, these patients, community acquired patients will actually present more sick. They are more sick. Why are they more sick? They are more sick because they do have a certain SCC MEC gene, which is 4 and 5, which encodes for a certain toxin called as PVL toxin. Panton Valentine leukocidin. Panton Valentine leukocidin. Now this Panton Valentine leukocidin is a toxin that will actually dissolve various parts, cause protein peptidoglycan to actually dissolve, and thus cause necrotizing features. So Panton Valentine leukocidin is like a hemolysin toxin, which actually is responsible for causing necrotizing picture. So these patients will present with necrotizing pneumonias. They will present with necrotizing skin and soft tissue infections. They will come with all these kind of phenomena, community acquired MRSA. They have Panton Valentine leukocidin toxin, PVL toxin. This PVL toxin is encoded by the SCC MEC. That's why I said it starts with SCC MEC 1 to 5. Okay, whereas this side, hospital acquired, the SCC MEC is 1 to 3. And they don't have PVL. They don't have PVL. Okay, so that's the hospital acquired organism versus the community acquired organism. Now, when you go ahead on understanding hospital acquired and community acquired, the treatment also is differing. Now, for example, if you have a small furuncle or a boil and it is community acquired MRSA, classically, though they have PVL toxin, they'll respond very beautifully to even ceftriaxone and clindamycin. They'll respond beautifully to ceftriaxone and clindamycin, which are stock drugs you can give orally. Okay, so that's why community acquired MRSA, you may want to give clindamycin, so simple tablet, you just give it and be fine. For example, you've got a boil here, there. At home, he's got a boil here, there. You give ceftriaxone, give clindamycin, because it will respond very beautifully to both those drugs, clindamycin as well as ceftriaxone, that's cotrimoxazole, trimethoprim. Okay? This is very simple. You can even treat with doxycycline. I mean, you don't need anything more, you can even treat with doxycycline, that's what she was mentioning there. Now you can even treat with doxycycline. You don't need drugs that are higher. We don't talk about linezolid because it's a reserve drug for TB. So we don't talk for that. Okay. When we come to drugs, we'll talk about which drugs where and what. Okay. So this you can treat here. Unfortunately, hospital acquired MRSA may not respond to clindamycin as well. It may not respond to clindamycin as well. So one of the keys is look at what your phenotype is showing. If your phenotype shows clindamycin resistance, you're mostly veering towards hospital acquired MRSA. You're veering more towards hospital acquired MRSA. And our worry with hospital acquired MRSA is it's not just a drug that works, it's also the body that fights the infection. So our hospital acquired MRSA patients unfortunately are sick enough and so sick that they may not ward off that infection, and that infection might become chronic, or that infection might not go off, or that infection might become metastatic. You understand? So our problem with hospital acquired MRSA is the fact that this may not move out of the body. A community acquired MRSA, just give him a drug and he's fine, boom, he's fine. You understand? But a hospital acquired MRSA will have this kind of problems. You understand? And that is the reason that one of the drugs that we are using in a skin and soft tissue infection of a community acquired nature is actually clindamycin. Because there is something, there's a huge amount of toxin that might be released, and this has an anti-toxin effect also. Clindamycin has got an anti-toxin effect also, which actually prevents the patient from deteriorating very badly. And that's why clindamycin figures very high on the SSTI list. It figures very high on the SSTI list. So in short, if I'm going to give for hospital acquired MRSA a drug like, let me take the example of vancomycin. Now vancomycin does not have the anti-toxin effect. It does not have that anti-toxin effect. Since it doesn't have the anti-toxin effect, I will still need to give clindamycin along with it. You understand? Because there is no anti-toxin effect to that. Especially when you're thinking of a diagnosis of necrotizing skin and soft tissue infection, I would want to give an anti-toxin effect. One of the drugs among the group of vanc, linezolid, ceftriaxone, doxycycline, and what about daptomycin? One of the drugs that actually has an anti-toxin effect is also linezolid. One of the drugs that also has anti-toxin effect is also linezolid. So that's why it comes in the guideline for community acquired MRSA. You understand why it is placed in the guideline for MRSA? Because linezolid also has got an effect, an anti-toxin effect. Clear, it's got an anti-toxin effect. That's why it comes. So now you understood what could be the drug of choice when it comes to simple community acquired MRSA. In simple community acquired MRSA, you'll probably be able to deal with doxy, ceftriaxone, clindamycin, and linezolid. And why linezolid and clindamycin are important is because it's got its anti-toxin effect. Whereas when you look at hospital, look at MRSA, you would probably be resistant to many organisms and you'd require directly to give drug of choice being vancomycin. Where, what, when we'll come to that. Where, what will come to that. Clear on this? So now we've basically understood community acquired MRSA versus hospital acquired MRSA. Now let's go to a very pertinent topic, how to treat these things in the first place. So we'll go directly to bacteremia in the first place. Okay. So our biggest problem that we have is with bacteremia. This is our biggest problem. When we come to MRSA, our biggest problem is going to be bacteremia. It's going to start by, you must know bacteremia inside out when it comes to MRSA. Okay, it comes in MRSA because that's how in intensive care you're going to see them. You're going to see them with bacteremia. That's how you're going to see them in intensive care unit. You might not see them as pneumonia MRSA. You might not see them as VAP MRSA. You might not see them as UTI MRSA. You might not see that at all. You might see them as bacteremia in the first place. Okay, that's what we're going to see. Okay, skin and soft tissue infections, you might generally end up getting streptococcus, staph aureus in the ICU causing necrotizing features. Also, you may get, but what you should know is first and foremost is bacteremia. And I told you why. Because it's got this very nasty tendency to go and get seeded to different places. So when you say bacteremia, there are two kinds of bacteremia. One bacteremia is the one that is called as complicated and that's called as uncomplicated. Complicated and uncomplicated. In bacteremia itself, there are two kinds. One is called as complicated and other is called as uncomplicated. And when do I call it as complicated? When do I call it as complicated? I call it as complicated when this bacteria has moved from here to a metastatic site. For example, this person has developed a meningitis. This person has developed a vertebral osteomyelitis. This person has developed a splenic abscess. This person has developed an infective endocarditis. That's called as complicated bacteremia. Clear on this? Or it can also be called as complicated bacteremia when you have the organism and you have some prosthetic inside. For example, you've got a pacemaker wire inside, you've got a dialysis line inside, you've got a perm cath in place, you've got an IV, internal jugular, you've got a long-term PICC line. So you should be able to say complicated bacteremia versus uncomplicated bacteremia, and that's very important for you, very important. One of the commonest causes to call it complicated bacteremia is when you do not manage to remove the bacteria. How do you do that? So that means every patient who comes in with MRSA, every patient, if you get blood culture on day one you send a blood culture, you thought that this is MRSA, so you actually put this patient on vancomycin. Okay, you put this patient on vancomycin. In the next 48 to 72 hours, I need to send a second blood culture. It is essential. It is essential to send the next blood culture in 48 to 72 hours, ideally 72 hours. I will send the next culture in 72 hours. This is essential. You don't have to ask me for this. Patient comes in with blood culture, you have to repeat positive staph aureus. 72 hours later, you have to send repeat blood culture. Why? Because if the repeat blood culture again grows the organism, you have now moved from uncomplicated bacteremia to complicated bacteremia. You have gone to complicated bacteremia. Not only that, now you have to start thinking, is my focus changed? Is my bacteremia gone metastatic? You have to start thinking that way. So as a doctor in the ICU, you do a blood culture, you find that to be MRSA positive. Okay, third day you repeat it. First of all, you have to remember to repeat that MRSA. You repeat that. On third day you get that MRSA again. So you stay thinking, oh, this is complicated bacteremia. I need to now figure out where else I'm going to have this. Is it going to be in the vertebra? I start examining the spine. I start examining the eyes. I start examining the spleen. I start examining all the places. I look for lines because lines are something that may be causing this. Okay, I need to pull off those pacemakers. I need to pull off those pacemaker pockets. I need to remove those PICC lines. I need to remove all those perm caths. You understand? I start thinking like that. And importantly, I do a very important investigation in this case. A very, very important investigation at day 4 and day 5. And the investigation that I do in this case is usually a transesophageal echocardiography. Very essential. And day 4, day 5, I start looking at a transesophageal echocardiography. Why not do it on day 1? Because on day 1, if you try to do it, the chances of false negative is very, very high. The chances of false negative here is very, very high. That means the patient actually has infective endocarditis, but you are not able to diagnose it. That's why at day 4, day 5, that is the time when the valves are actually seeded and you can actually see them very well. Okay, and that's the time you do a trans-esophageal echocardiography. At minimum, there has to be a transthoracic. A good clinical examination will reveal changes of murmurs. Okay, and these patients will present very sick. Okay, and that will give you a diagnosis of trans-esophageal echocardiography showing valvular endocarditis or infective endocarditis. Clear? And why is that important? Because the entire duration of treatment and drugs change. The entire duration of treatment and drugs change. Okay? Clear on this? Now, what has happened over here? What is so different in infective endocarditis versus normal? What is so different? What do you think is different? Arshad, what do you think is different? Infective endocarditis and normal bacteremia, what's the difference? What do you think is the difference?
Focus is in.
So, focus would be in the lung. What is the difference here? What's the difference here? The difference is that whenever you have valvular endocarditis, the inoculum load, the amount of bacteria at a certain small spot is very high. It also forms something like a biofilm where the penetration of the organism is, or of the bacteria is not, of the antibiotic is not very good. So when you're looking at infective endocarditis, that is why these patients do not remove the organism quickly and they may require extended duration of therapy up to 6 to 8 weeks. They will require up to 6 to 8 weeks. Clear on this? So whenever you have infective endocarditis, you should start thinking native valve endocarditis or prosthetic valve endocarditis. That means there are two kinds of endocarditis. One, when the valve is normal and it has got infected, and the other is prosthetic valve endocarditis. Both very difficult to treat entities. Both extremely difficult to treat entities. Right? So what is the treatment for what is the difference in treatment? I just talked about the duration being different. The first thing is the duration is completely different. For a necrotizing, maybe for a small impetigo, I might give 7 days of treatment. If it's bacteremia, I may give 14 days of treatment. But if it goes to infective endocarditis, I'm giving 6 to 8 weeks of treatment, minimum. 6 to 8 weeks of that's minimum, that's at minimum. And then I will again check for transesophageal and again do blood culture, again do CRP and figure out whether I should really continue the antibiotics or not at 8 weeks, again and again. And that's how I'm going to do it. The difference over here is I will probably add a combination of say vancomycin plus gentamicin plus rifampicin. This is where I am changing my treatment. I am adding all three together. I am adding vancomycin at good doses. I am adding gentamicin at the recommended doses, and I am adding rifampicin at the recommended doses. I never will add rifampicin immediately after this time. I will add rifampicin at day 4 after starting vanco and gentamicin. I will not start it immediately. I will start rifampicin at day 4. The dose being 600 milligrams twice a day, and this treatment will go on for say 14 days. The rest will go on for 6 to 8 weeks. Okay, the vancomycin will go on for 6 to 8 weeks. Rifampicin will go on for say 14 days, and gentamicin maybe for a week. It doesn't go on for a long time. Clear? This is just to ensure that there is killing quickly, so that we remove a big bioburden. Giving long-term aminoglycosides can be quite disastrous for this particular patient, and that is the reason. Now, unfortunate over here is these treatments can't be done orally. There are no oral treatments for this. It has to be IV. The entire thing has to be IV. The entire thing has to be IV. Clear? Entire thing has to be IV. Unfortunately, the entire thing has to be IV. As much as possible, it has to be intravenous. So that's where infective endocarditis becomes very different from otherwise. Otherwise, a skin and soft tissue infection you can convert to an oral switch very quickly. Whereas here you can't do that. You have to be looking at it, because what can happen in infective endocarditis, it can be fatal. It can be fatal because it can cause valvular erosion, necrosis of the valve, and then the patient dying because of that. You understand? Valvular erosion, necrosis of the valve, and patient can die. Remember this, source control becomes difficult here. What is the first mechanism of sepsis treatment? Source control. Here, source control becomes extremely difficult because of the fact that I can't just open up the heart and remove the valve out. Are you understanding? So it is a very difficult task, though we have done it in the past. It's a very difficult task. Patient does not do well. Patient has very difficult courses. These patients may suddenly arrest. They go into sometimes septal defects. They might go into any kind of arrhythmias. So a lot of other things happen in these cases. So that's why you must be very careful, and that's the reason that you should follow the algorithm like I mentioned. You start blood culture, 3 days later repeat blood culture, do a transesophageal echo, figure out whether there is valvular pathologies, and then you go further ahead. Clear on this? Clear on this? Because the treatment will change. If it becomes IE, the treatment will completely change. Clear? Clear on this? So that's about bacteremia. Now that's about bacteremia. Clear? Any questions on bacteremia?
So it can entirely stop after 2 weeks.
Yeah, so about 2 weeks. Some people start for 5 days also. So the protocols are quite different when you look at IDSA, when you look at European Society, when you look at American Society. The protocols are very different. We probably say, let us put gentamicin for the next 8 to 14 days and stop it at that level. Look at patient, look at how the patient is doing. Infective endocarditis patient very morbid. What happens with them is they develop fever. Recrudescence doesn't come. It just keeps on happening. CRPs don't come down, patients doesn't improve because they are continuously seeding the organism into the bloodstream. Every beat of the heart is probably releasing a bacteria into the bloodstream. You understand? And that's the reason that they don't look good. They look very moribund. They look very moribund. They don't do well. And that's the reason that you can actually see recrudescence. You can actually say, oh, this patient got better. You can actually see it. It's very objective. The pulse rate has settled, BP has settled, patient looking better, patient is eating food. That's how it is. And that is the reason that optimization of vancomycin becomes very important. Very important. Very important when it comes to treatment of staphylococcus. Optimization. Okay, because if the drug you are giving, if it is not the right dose, you have not done the right thing at all. Because that's your drug of choice. So among the drugs that you have for any of these infections of Staphylococcus aureus, which are the drugs that you know? For MRSA, okay? What about MSSA? What about MSSA? You know, I had this habit, Vicky karke mere paas ek doctor tha, I should not be naming it on camera, but he used to sleep during my, very often, and my target used to be trying to keep him awake. Okay, so similarly, Amit is my target now, Amit, go and stand there. हाँ? उसके बाद वो उधर खड़ा लेके सोता था, तो उसके बाद उसको एक टांग पे खड़ा करता था. I really did this because it was my target. Because it's very difficult to actually otherwise talk to somebody who's sleeping in front of you. Huh? All right. So, what do we? When you're okay, when you're awake, when you want to have a coffee, we'll have a coffee and come. Huh? So, where are we? So MSSA. What is the drug of choice for MSSA? Sorry? We can use Ceph. Which one?
Class 5.
Which one?
Third generation.
No. So I last time discussed with you all. Cephalosporins are from class 1 to class 5. The class 5 is cephadira-col. Class 1 is cephazolin. Okay. Starting from here to here, the gram-positive cover reduces. The gram-negative increases. So the most best antibiotic for a gram-positive organism, Staph aureus, has to be cephazolin. However, when it comes to MSSA, there are clear data that actually talks about the fact that anti-staphylococcal penicillins are even better than cephalosporins. Anti-staphylococcal penicillins. And which are those anti-staphylococcal penicillins? Which are those? Flucloxacillin, dicloxacillin, cloxacillin. So the answer to the question of what will you give for MSSA, the answer is cloxacillin. Now, okay, I want to give cloxacillin. What is my problem with cloxacillin? What is my problem? The problem is the dose frequency. When I am giving cloxacillin, it is given 2 grams every 4th hourly. Every 4th hourly given 2 grams. You're giving so high doses, 12 grams of phosphor. You're giving, you're giving 12 grams. So 12 grams is not a small dose, it's a very large dose, cloxacillin. So 12 grams means you are giving him IV, har 4 घंटे में. That means it's very difficult to actually put this patient at home. If you put this patient at home and give cloxacillin, it's very difficult. That's why oral cloxacillin is available. We try to give oral cloxacillin. You understand? So why not just give vancomycin? I mean, it's just so simple. Why not just give vancomycin, Ashok? Why not give vancomycin? It's simple, no? Just give vancomycin. Staph aureus, gram-positive, just give vanc. It's simple. Why not just give vancomycin? Because it has been proven that microbiological outcomes and clinical outcomes are extremely poor. In fact, more than 30% mortality when you actually give vancomycin in place of anti-staphylococcal penicillins. That has been proven. It has been proven that though vancomycin is talking as a great drug, linezolid we're talking as a great drug, we're talking teicoplanin as a great drug, we're talking of limodadicloxin as a great drug. Unfortunately, studies have clearly demonstrated
Madam taking lecture.
Huh? So unfortunately, it is something that causes. It's something that is. We know that in studies that when you give vancomycin versus when you give cloxacillin, okay, the ones when you give cloxacillin, the microbiological cure and clinical outcomes are much better. In fact, mortality is high when you go to use vancomycin. So it's almost 3 times the amount of mortality that you might get when you use vancomycin. You understand? And that is the reason that I said that if you're thinking of Staph aureus, I need to even give some kind of beta-lactam antibiotic. So empirically tomorrow if I'm thinking of Staph aureus, I would probably give vanc and a beta-lactam antibiotic. Maybe cefazolin as well as vancomycin. Whether cefazolin is superior to cloxacillin, that is not very evident, but there are observational data that says cloxacillin is better than cefazolin. There is observational data. Of course, randomized controlled trials are the best data. We don't have that kind of randomized controlled trial, but we know cloxacillin seems to be much better when it comes to antibiotics against Staphylococcus aureus. But tomorrow, if you have a patient who comes and you empirically want to cover Staph aureus, what will I add now? What will I give empirically? Sorry? And yeah, because I will not call MRSA, na? If I am looking at Staph aureus, it could be either MSSA or it could be MRSA. It could be either MSSA or it could be MRSA. And we know that if I give for MSSA vancomycin, the outcomes are poor. We know that. So I can't give for MSSA vancomycin. And I know that MRSA cannot be treated with cefazolin. So what will be my combination? Cefazolin, the beta-lactam antibiotic along with the glycopeptide like vancomycin. The combination would be cefazolin plus vancomycin empirically in such cases in which I clearly feel that there is gram-positive Staphylococcus aureus in place. Clear on this? Clear? Any questions here till now? Any questions? Any questions?
Severity of disease with MSSA.
So what severity of disease? No, you can't figure out on that. Can't figure out on that. Okay.
But we get MSSA, like when we get a staph, we get it is MSSA or MRSA. When at that time, Vanco we should not like it is MSSA then.
MSS, what you will do?
So Vanco should we give that time?
Will you give it?
No.
Then what is the answer of your question?
So like combination will only supposedly
Yeah, you don't require a cefazolin also. Just go to clox.
logs.
Just go to cloxacillin, which we feel is better, which we all know is better. Are you understanding? And why is this better? Why is this better? Why is cloxacillin logically better than, though cloxacillin has got its problems, cefazolin you can give twice a day. Cloxacillin you only give 6 times in the day. So it's problematic to give cloxacillin 6 times a day versus cefazolin twice a day. It's very easy to give Reflin 1 gram twice a day. Right? Unfortunately, we are not giving we have to give this 6 times a day because of something called as inoculum effect. Now, what is inoculum effect? Inoculum effect is when a group of organisms are lying in one particular place, the antibiotics doesn't work as well. In that aspect, it's the clox that works better than cefazolin. It's the clox that works better than cefazolin. That's why the inoculum effect, logically, the inoculum effect is seen playing a very important part. Inoculum effect. It's the inoculum effect that is playing a very, very important part. Very, very important part when it comes to cloxacillin versus cefazolin. Clear?
Is there any difference between MSSA or MRSA in lung or in blood?
The difference in the
Lung infection or?
we'll come to lung now. We'll come to lung. I'm not even touched lung till now. I'm not bacteremia mein abhi bhi. We have not moved out from bacteremia. We are now also in bacteremia only. We haven't moved out to lungs. We'll come to lungs. Okay. Clear on this till now? Huh?
So we follow same protocol for the artificial valvular infective endocarditis.
For infective endocarditis, it's always vancomycin has to be there along with rifampicin and gentamicin. It has to be there. That has to be a combination.
And for prosthetic valve, if it is involving prosthetic
Where?
yeah, so same medication.
Same. But you're adding rifampicin and gentamicin. That's not there here.
No, I mean to say that.
Yeah.
follow that.
Clear? Prosthetic valve, we may not want to start gentamicin. If we just vanco, we will not start rifampicin. Just vanco and genta might be enough. Okay, in prosthetic valve. There is a small discrepancy in data when it comes to IDSA and European Society and AHA. There's a small discrepancy. One says use 2 only, other says use 3. Practically, I feel use 3. If the creatinine is okay, use 3. Practically I feel, because there's a small discrepancy between AHA protocol and the IDSA protocol. That's why. So all three is better to be used. Vancomycin, Genta and rifampicin. Huh? Levothyroxine we're not even talking about because the indigenous molecule just come in, not FDA approved till now. Yes, it has just got quality control FDA approval, not really US FDA approval. It's not coming in the guidelines. So I would not really tell anything away from the guidelines as of now. Okay, so we will have to talk as to guidelines, as to what we are supposed to do. Okay, there is among the group of drugs there is vancomycin. There is for MRSA. Let's not confuse. For MRSA, for MSSA we know. MSSA we are clear. For MRSA, the drugs that we're going to use are usually going to be four or five of them. She did touch upon it, but I'll just touch upon it again. For MRSA, the drugs that we'll probably use, before we go to symptom of lung and before we go to UTI, we need to know the drugs also. So drugs we're going to use so that you can understand why to use where. Okay, what are the drugs you can use? Vanc, teicoplanin, then linezolid, clindamycin. Let's not put clindamycin here because it's not going to be against MRSA. We said MRSA, community acquired MRSA and hospital acquired MRSA. So when you say hospital acquired MRSA, it might not respond to clindamycin. So we are looking at MRSA that's there in the hospital. Okay, so clindamycin is not something I'll add over here. You understand, na? Community acquired MRSA, yes, clindamycin.
But in soft tissue, no.
Yeah. So for antitoxin effect. But let's get talking about MRSA. Don't think of clindamycin as MRSA. Otherwise you'll start thinking MRSA, clindamycin. It's not MRSA. Don't consider MRSA, clindamycin. It's not right. Okay, I explain to you because there is CA-MRSA and hospital MRSA. CA-MRSA might respond to clindamycin. Hospital MRSA might not respond to clindamycin. So let's not talk about clindamycin when you're looking at MRSA. Clear? Because if you're giving something, you want to cover MRSA really. Okay, so you have vancomycin, you have teicoplanin, you have linezolid, then no, again same problem. So linezolid, then quinaprisin, dalfopristin, not very widely used. Daptomycin, the US cefadiracol, and telavancin, oritavancin, and dalbavancin. Newer drugs, lipopeptides. Okay, so there are so many drugs that you have in your hand. When you look at gram-positive cover, you do have a good number of drugs, especially for MRSA. You have vancomycin, you have teicoplanin, you have linezolid, you have daptomycin, you have cefadiracol, which is 5th generation cephalosporin. We just talked about the fact that gram-negative cover increases, but this is the only cephalosporin at the 5th generation where it is actually having MRSA cover also. You understand? It's the 5th generation cephalosporin. It's completely different from what we discussed. We said grade 1 to grade 5 cephalosporins, you will start losing gram-positive effect, right? This is the only one which is actually active against MRSA because it's got a very different and unique mechanism of action with respect to PB2A. It's got a completely different mechanism of action with respect to PB2A. Our problem is PB2A. This has got a completely different mechanism which is basically bypassing the PB2A pathway and thus causing cell lysis. You're understanding? So cefadiracol. And you have daptomycin and then telavancin, oritavancin and dalbavancin, which is just entered into the market as of now. Right? And then you have the indigenously developed molecule of India, which is called as levothyroxine. This is indigenously developed. That is, this is a molecule that is from India. So indigenously developed levothyroxine. So putting all of these and putting in short everything, you should know vancomycin very well. Why you should know vancomycin very well? Because it still stands as a drug of choice. It still stands as a drug of choice. That's why you should know vancomycin very, very well. It still stands as drug of choice. You just tell Megha to give me a coffee. Clear on this? Any queries till now about the drugs? Okay. Now, there are certain unfortunate things also. The unfortunate things is that the US FDA has not approved teicoplanin. US FDA has not approved teicoplanin. And since it has not approved teicoplanin, the studies are not very great when it comes to teicoplanin. We don't see so many studies and data that comes from teicoplanin. Are you understanding? We don't see so much of data. So tomorrow when you see a IDSA guideline, you will not see teicoplanin mentioned anywhere. So don't think, teicoplanin kahan gaya? It's not there only because it has not been registered by the FDA in the United States. And since United States are one of the prime drivers of research, we don't have too much of research coming in from teicoplanin, and that's why the approvals for FDA is not there, and that is why we are not really putting it in the guidelines everywhere. It's not there in many guidelines. So don't be surprised if you don't see teicoplanin. That doesn't mean it doesn't work. It is still a glycopeptide. It works in the rest of the world, apart from US. It's used in the rest of the world. Clear on this? Huh? So vancomycin is one of the major important glycopeptides that we have that we should know inside out. Vancomycin has to be dosed very well. And what is the PK/PD for vancomycin? Which is the characteristic of vancomycin where you are going to concentrate? You know, we have, when we talked about PK/PD the other time, you already did it. We have PK/PD, right? And when you say PK/PD, what are the various PK/PD that we knew?
Volume of
Time dependent.
Time dependent.
Dependent.
Concentration dependent. In concentration dependent, what we talk about? Peak over MIC.
Peak over.
That is the Cmax effect.
time.
We talked about a post-antibiotic effect. Huh? And in time dependent, what we talk about? Time over MIC, or we say AUC above MIC. 24-hour AUC above MIC. This is what we discussed. We discussed this. We discussed the fact that there are two kinds of antibiotics. One that is concentration dependent, another that is time dependent, and one that is a combination of all two, both of them. And broadly speaking, those ones that are concentration dependent, we need to give it at a very high dose once a day because it has got a post-antibiotic effect, because the entire killing will depend on that peak over MIC. And that's why the classical example of this peak over MIC is aminoglycosides. And that's why we give amikacin once a day, 15 milligram per kilogram, once a day is the dose. It has got a post-antibiotic effect, right? Whereas there are another group of antibiotics where the time over MIC, time of the antibiotic concentration in the blood over the minimum inhibitory concentration for that antibiotic should be up for at least 40 to 50% of the time. You are understanding this? Understood, or should I repeat this? There is no harm in saying to repeat. If you don't understand, don't just shake your head. Huh? You understood? No. So, you have an MIC. The antibiotic has to be above the MIC. This is MIC. This is the concentration that the antibiotic needs to be above. Okay. When I do, and let's convert this into a 24-hour window. 0 time to 24 hours. When I'm doing peak over MIC, my antibiotic I'm giving at time 0. It's going up, coming down. So, at good period of the time of the day, the antibiotic concentration is below the MIC. In spite of that, it is working. In spite of that, it is working because it's got a post-antibiotic effect. The classical example of this is aminoglycoside. Right? When you say time over MIC, means I'm going to put a dosage interval. Let me put it as 8 hours, 16 hours, and 24 hours. I put it as dosage interval. Okay, I put a dosage interval here saying time 8 hours, 6 hours, and 24 hours. When I say time over MIC means what do I want to do? I want to keep the concentration of the antibiotic above the MIC for at least 40% of the dosage interval. My dosage interval is this 8 hours. For at least 40 to 50% of the dosage interval, my antibiotic should be above the MIC. Clear on this? This is a difference from what it is. So I will redose the patient again. I don't have a post-antibiotic effect. I'll redose again. And I'll keep it 40 to 50 times above the MIC. Clear on this? And when I say 24-hour AUC by MIC means the entire concentration above should be as much as possible above the MIC. At least 40 to 50% of the times above the MIC. So the ISCA combination together should be at least 40% over the MIC. This is the entire MIC. Clear? 24 hours. 24 AUC by MIC. Clear on this? Clear? Huh? Vancomycin follows which order these? Vancomycin actually follows AUC by MIC. AUC by MIC. Vancomycin actually follows AUC over MIC. And what it follows is that we have to keep the AUC over MIC ratio as 400. It's a ratio. When you do serum levels to MIC, you get a ratio. That ratio, if you want to keep it at 400, means you have to dose it at very high doses. So it goes to 20 to 25 milligram per kilogram of vancomycin twice a day to actually keep the AUC by MIC above 400. 400 to 600 is what you need to keep. Clear? This means to say you have to dose it at such a dose that it may cause what? Renal toxicity. You are dosing at such a dose which may actually cause renal toxicity. Right? Renal toxicity. This is something that may cause. Okay, renal toxicity. Clear on this? Clear? Clear? Renal toxicity. So when it's above AUC by MIC of 24 hours, there is a very high possibility that you may get renal toxicity. Clear on this? So I have to effectively take care of the AUC by MIC. At the same time, I have to take care of the renal toxicity. You understand the problem here? समझ में आ रहा है? हाँ? So that means I need to dose vancomycin aggressively. I have to dose vancomycin aggressively, especially we know that if it's MRSA, I treat it a lot late, I will lose the patient. So I need to dose it aggressively. You understand? That means there's a very high possibility, and my entire effectivity is based on my UC by MIC. My entire effectivity is based on it. So I'm not really looking at toxicity at all. You understand? When I'm thinking vancomycin, I'm not thinking toxicity. I'm thinking of effectivity. So tomorrow, if I want to target vancomycin and give the best possible treatment, I need to target AUC by MIC of 400. That means I need to take levels inside the body after the 4th dose of vancomycin. Near about the 4th day. Just before the 4th day, I will take vancomycin levels, trough levels. Okay, and then calculate my UC by MIC. I am dosing aggressively. I'm not looking at toxicity. In toxicity, what do? I do trough levels. In toxicity, what do? Trough levels. I do a dose, after some time I do a trough, and I figure out what's happening. That's toxicity. Here what I'm doing, I'm waiting for 3 days, and then I'm taking vancomycin because I want to achieve that AUC by MIC of high levels. So dosing vancomycin aggressively is very important, and that's the biggest problem with vancomycin. I need to dose it aggressively. And when I dose it aggressively, I do develop nephrotoxicity. That's the biggest problem with vancomycin. Right? Now let's go and understand teicoplanin. Now you understood vancomycin? But what is important about vancomycin is, it is bactericidal. It is a drug of choice. It has time tested. It has been proven for a long period of time that vancomycin works. That's why vancomycin is a great drug. Okay, and most of the studies that we've done is non-inferiority studies. That means we compare vancomycin to other drugs. You understand? That's what non-inferiority study means. You can this drug, that drug, are they non-inferior to each other? That's what they basically look at. Okay, so most of the drugs have been compared to vancomycin. Now, teicoplanin is a drug that is not available in the United States, but the characteristic of teicoplanin is again the same. It is again AUC by MIC, but the difference is it's got a very, very long half-life, up to 150 hours. Up to 150 hours. Now, when you have a half-life that is very long, what do you think? How will you adjust the dose? And that is also renal only. This is also renal, going through renal. This is also going through the kidney. This is also going through the kidney. So once you have half-life that is very long, what do you start thinking? If you want to adjust it, both you have to adjust the dose. If it's renal toxicity is there or the kidneys are not working well, I have to adjust the dose. The difference is, what is the difference? You think if there is a long half-life, how will you adjust the dose? If the creatinine levels is 30, how will you adjust the dose? Anyone?
Loading dose should be more, but next dose should be after some interval, some days.
Yeah, so that's what we normally do now. What do we do here? Compared to any other drug, what do we do with teicoplanin? See, if you just remember what you're doing in your ICU, no, you realize that that's your answer.
We are giving maximum dose.
No, so loading dose always remains the same. There is no change. Loading dose remains the same. But in this case, the loading dose will remain the same. Do what you're doing in the ICU. Evidence-based medicine is what's happening in the ICU. The loading dose is what we give is the same. But what do? We change the interval. We increase the duration of 48 hours to 72 hours, something like that. We can't reduce it to 200 milligrams once a day. Doesn't make sense. If you want to actually give teicoplanin and you want to dose it renally, what I will do, I will change the interval because it's got a very long half-life. And since it's got a very long half-life, I want to keep the AUC by MIC above the MIC most of the times. That's why I want to do this. If I give lower intervals, 200, what will happen? It will not reach AUC MIC. I understand if I lower the dose. I want to keep the dose high so that I dose it effectively. But then I don't want to redose it at the same rate because it has got a very long half-life. And since it's got a very long half-life, I will change the intervals. Are you understanding this simple point? Compared to otherwise? Clear on this? That's why we dose it like that. Clear? Teicoplanin. Then the other drug that you have is linezolid. Now linezolid works a completely different mechanism and is a fantastic drug when it comes to MRSA. Now why is it a fantastic drug? Because what happens is even head to head, skin and soft tissue versus vancomycin versus linezolid. Linezolid has got more effective cure, more microbiological eradication. Linezolid has got more effective cure, more microbiological eradication. But what you must remember? You must remember that linezolid, which is from the oxazolidinone group, it's from the oxazolidinone group. This is what linezolid is. What you must remember from linezolid is the fact that this is a bacteriostatic drug. compared to vancomycin and teicoplanin, this is a bacteriostatic drug. This is what you must remember. It's a bacteriostatic drug. Okay, so in cases where there is bacteremia, in cases where there is infective endocarditis, we are looking at bacteremia infective endocarditis, you really want to try to give a bactericidal drug. Okay, really want to give bactericidal drug. Though it has been proven that bactericidal versus bacteriostatic is the same, but we all in the back of our minds know I want to give a bactericidal drug. Okay, so in that case, giving linezolid may not be a great idea. Clear? Huh? Though it's a fantastic drug. If I am just having a skin and soft tissue infection, perfect to give linezolid. If there's no bacteria, it's perfect, absolutely perfect. Because why? There are multiple advantages of linezolid. One advantage is it doesn't have any problem with the kidneys. Second advantage, doesn't have any problem with the liver. Third advantage, you can convert the IV to oral anytime you want, because the bioavailability is 100%. That means if you give IV or I give oral, the bioavailability is the same. What is getting into the blood is the same. So you have a full bioavailability when it comes to linezolid. You understand? So it's a fantastic drug to give when it comes to any infection and gets into every organ very well, excepting the urinary tract. It gets everywhere well, excepting the urinary tract. It works everywhere. It gets into the brain, it gets into the, though we don't want to use it for the brain, I'll still use vancomycin because I'm not a bactericidal drug. But it can get into the brain. It has got the antitoxin effect that we want when it comes to endotoxin release. It has got the antitoxin effect. So it will work fantastically for skin and soft tissue infections. It will penetrate the tissues much better than vancomycin, which has been proven. It penetrates tissues much better than vancomycin, get into the lungs very easily, and it doesn't cause any nephrotoxicity, does not cause any ototoxicity, does not cause anything. Unfortunately, long-term use more than 14 days will cause pancytopenia, will cause thrombocytes to go down, number one, if you go it for more longer period of time. And second, the other problem that you have is these patients may sometimes go into something called serotonin release syndrome. We had one patient here who basically went to SSRI, was on bed number 5. Basically, the patient had come from the wards with tachycardia. It was SSRI, linezolid induced, which we stopped and he became fine. Remember that patient who had come, oncology patient, who basically came in with that fast heart rate, and then we were wondering what's happening with fever, with tachypnea. We just stopped the linezolid and the next day he was fine. Remember that patient or not? We gave him tocilizumab. Was the patient here? It was clear SSRI. Okay, with linezolid. So linezolid can cause this kind of problem. Okay, it can cause this kind of problem where you can have serotonin release. Clear? Clear on this? SSRI. Okay, so that's about linezolid, right? Now let's go to daptomycin. Daptomycin is another fantastic drug. Daptomycin is another fantastic drug. It is given at 6 milligram per kilogram. If you want to give it at 6 milligram per kilogram. It is one of the drugs that you would want to give when it comes to bacteremia. It's got a phenomenal bactericidal effect, which is very quick. It works very, very fast. But the only difference between bacteremia of usual bacteremia and infective endocarditis bacteremia is I will want to give a higher dose. Instead of 6 milligram per kilogram, I'll probably give 10 milligram per kilogram. And what you should be worried about when it comes to daptomycin, great drug when it comes to kidney also, just give it. You can just dose it like the way it is, 6 milligram per kilogram. But what you must remember is daptomycin is known to cause some muscle injury. It can cause some muscle injury, and that's why if the patient complains of some pain or you find some changes in the muscle, it's important to get a CPK level done. It's important to get a CPK level done. But what you must remember is, if you're looking at a multifocal infection, for example, the infection is in the lung, daptomycin is not going to work. It's not going to work at all into the lung. It's completely poor when it comes to lung because of the fact that it is completely inactivated by the surfactant of the lung. It's completely inactivated by the surfactant of the lung, and that's why daptomycin, when it comes to lung, it cannot be used. Not only that is a problem, compared to all of these drugs, daptomycin is the most expensive of the drug. So the expense actually goes very, very high when it comes to daptomycin. Okay, so 6 milligram per kilogram is the dose that you want to give. If you are giving 6 milligram per kilogram dose, I want to check the CPK. If I am going to give it for infective endocarditis, I want to give it for 10 milligram per kilogram. It's a great drug when it comes to urinary tract. Unfortunately, it's a very bad drug when it comes to the lung because the pulmonary surfactant will actually inactivate daptomycin. Clear on this? Clear on daptomycin? Huh? Then the next newer drugs which are not yet into the market, ceftazidime is there in the market, dalbavancin has come into the market, telavancin and oritavancin have come into the market. They are coming into the market very quickly. These are the drugs that are going to come in. I'm certain it's a cephalosporin, so very quickly it will develop a resistance mechanism because it's cephalosporins. But that is one of the drugs that can be used for MRSA. So it's a great drug when it comes to MRSA, cephalosporin, as of now, because resistance have not been developed yet. Whereas when you see dalbavancin and the rest, they are also great drugs. Why? Because it's a once a week dose. Dalbavancin is a once a day dose, whereas dalbavancin is a once a week dose. You understand? You give it once a week for 7 days, it's going to work very well against MRSA. So it's a fantastic drugs when it comes to outpatient therapy. If patient comes to your clinic, you have a foot that has grown MRSA, you give dalbavancin and call him after 7 days. It would be a great drug when it comes. It actually is coming. But the difference is the cost. Again, the cost. It's not that the drug costs the same cost. It actually costs 5 times the amount. Okay, so you end up paying the same cost. It's not cheap. You end up paying the same 25,000-30,000 rupees. Okay, but you get once a day, which is pretty good for a person who's going to take antibiotics. Anyways, these antibiotics are expensive. Okay, so it's good for a person because you give once a week and you call back on time. Of course, I don't have any knowledge about this drug because I haven't used it as well. I've not used it that well, but I want to use it because I don't do outpatient therapy as such with respect to infection. Others, I would have told you I've done this and I've done that. I've not done it. So I would not use it in the intensive care as of now because I still want a drug that I can start and stop. I still want a drug that I can titrate. I still want a drug that I can change. For an outpatient therapy, it seems to be a great drug of choice. Okay, that's what it looks like. Dalbavancin, oritavancin and telavancin. So this is about the entire drugs. Apart from this, there is another indigenous molecule for us, levonoreploxacin. Levonoreploxacin does not gain resistance because it works against NORA efflux pumps. It works completely different mechanism called as topoisomerase, because of which it really doesn't cause any resistance mechanism. So there is no resistance. Levonoreploxacin is not a quinolone. Okay, it's not a quinolone. So it doesn't really go and interact with TB drugs. Like we talk about quinolone and TB drugs, this will not interact with TB drugs. It's a completely different drug. Okay, it works on topoisomerase, which is a completely different mechanism. Okay, that's why it evades NOR efflux pumps. NOR efflux pumps. This is something called efflux pumps. I told you when you resistance mechanisms, there are 4 resistance mechanisms. One is called as alteration of protein binding to target sites. The other is called as beta lactamase or hydrolyzers. Third is efflux pumps. So we talk about efflux pumps, no? Most of these quinolones have got this problem with efflux pumps. Most of these quinolone like drugs have got problem with efflux pumps. This evades that NOR efflux pumps because it works on something called as topoisomerase. So that's why levonoreploxacin is a good drug that prevents resistance. It doesn't really have resistance. It has got all the good mechanisms that linezolid has. That means it has an IV to oral switch. It has got an IV to oral switch. You can actually give it IV to oral and nothing. Bioavailability is 100%. Okay. It has got all the good points of linezolid, but not the bad points. It doesn't really cause pancytopenia. It doesn't cause SSRI. It doesn't cause thrombocytopenia. It's got a better lung penetration. It can penetrate the lung very well, and it works very well in acidic environment. See, most of your abscesses are acidic. Most of your abscesses are acidic because of the pH being on the lower side. This will work very beautifully when it comes to acidic environment. Okay, this will work very well when it comes to acidic environment. Okay, so levonoreploxacin is known to work very well. Not only that, it actually enters the alveolar macrophages. Since it enters the alveolar macrophages, it will actually work very well in the particular organism, with the particular issue. The only place where it will not work is probably the brain and the urinary tract. That is where it doesn't penetrate. So it doesn't penetrate into the brain and doesn't penetrate the urinary tract. It doesn't cause seizures as quinolones do. This doesn't do that. So in short, this indigenously developed molecule could be a very good molecule of the future. But just like teicoplanin, it's not there in the United States. It has just got quality approval FDA. It just has got that specific denotion in the FDA as of now. But very soon, if the FDA takes it up, which is a long process and tedious process, we might see levonoreploxacin into the guidelines. But as of now, it is not in the guidelines. That's why you may want to use it. My relative, I would use it because it's fantastic. Is it there in the guideline? No, it's not there in the guideline though, because it's difficult for me to dose vancomycin at 20 to 30 milligram per kilogram. It's difficult for me to give linezolid for more than 14 days if someone has osteomyelitis. If the patient has got a lung infection, it's difficult for me to give the patient daptomycin. Whereas this supersedes all those, and that's why I feel this is one drug that may be a good drug. But as of now, we can't say it as the primary drug. It could be an alternative when other drugs cannot work. Clear? Clear on this?
Also Sidal, sir. Levonoreploxacin is also Sidal.
Sidal. It's a bacterial Sidal. So I've done a few research on this. So I know quite a bit about the drug. So I've done around 3 papers on levonoreploxacin. There's one more consensus guidelines coming out next week. Not next week, next month on this levonoreploxacin. So that also I've already written. Okay, so I've done a fair bit of research, so I can talk about the drug as well. Yeah. So we'll stop as of now with respect to MRSA, and we'll give it an answer yet. Okay. So in 2000, up to 2000, vancomycin was the workhorse antibiotic. Up to 2000, up to I was studying. मेरा भी चल रहा था. When I finished my intensive care, Vanco. You give Vanco every single place. Vanco was like patient comes, patient is hospital acquired, you give vancomycin. This was how it was. It was a combination of ceftazidime and vancomycin which I used to use on a regular basis. Ceftazidime because it works against pseudomonas and vancomycin because it works against MRSA. This used to be what happens. This was usually what happens. Now, I was part of that history where we used vancomycin and now you barely see me using vancomycin. Isn't it? So what really occurred? Did I just feel that, oh, I don't like this drug? Or what happened? What happened was very interesting. We know that in 1940s we talk about stories where penicillin was introduced and next year it became resistant. We hear about stories like that. We hear about stories that in 1960 methicillin was introduced, in 1961 methicillin got resistant. Gets it? We hear about stories that things get resistant immediately. Similarly, when Vanco came in, up to 2000 we didn't know only resistance, we didn't know only that Vanco can be resistant. But in 2001 onwards we found patients who are getting clinically not well. Even after giving vancomycin, they are really not getting well. They are not getting well. Vancomycin dene ke bawajud, they are not getting well. So we thought something is really wrong. Okay, so that is why what we found was, so she did allude to that MIC of less than 2 is actually supposed to be sensitive. Now she did mention one statement, MIC less than 2 is said to be sensitive. But there is a phenomenon called as MIC creep that has developed. MIC creep with vancomycin, which basically means that the MIC has slowly gone up. So your existing dose of vancomycin, even though it's sensitive, is getting resistant. You understand? So even if it is 1.5, that's in the center, they are not responding well. Okay, they are not responding well. And that's why this is called as vancomycin intermediate susceptibility Staphylococcus aureus, VISA. Vancomycin intermediate susceptibility Staph aureus, VISA. So how will you get around VISA? If I have to use only vancomycin, I have to give elephant doses. I have to increase the doses to such high amounts that you will go into renal toxicity. You understand? Initially we are aggressively dosing it. Now if I have VISA, I have to dose it super aggressively. And I'm 100% going to have renal issues. I'm 100% going to have probably 30, 35, 40 milligram per kilogram. Because I want to keep the AUC-MIC high. And to keep AUC-MIC, what has happened? The MIC has gone up. Since the MIC is creeped up, to keep AUC-MIC up, I need a larger dose. Are you understanding? So VISA is something that is there. So rather than actually changing vancomycin, I'll just change the drug. I'll go to linezolid. Are you understanding? I'll probably go to daptomycin. I'll probably not give vancomycin here. Clear? VISA. Then subsequently in 2000, after that, very quickly, Japan actually reported VRSA. This vancomycin resistant Staphylococcus aureus. So there is this entity called as VRSA also, which is vancomycin resistant Staphylococcus aureus. So though it's MRSA, though the drug of choice is vancomycin, it is still not responsive to vancomycin because it is VRSA. In short, if you have the MIC to be 1, it makes sense. I'll share one small paragraph about MIC. So if the MIC is 1, it makes a lot of sense to give vancomycin because it's a drug of choice. If the MIC is 1, so that's why you look at the MIC. But if the MIC is 1.5, though it is less than 2, which means sensitive, these automated analyzers can be plus or minus 1. So 1.5 could be 2.5 or it could be 0.5. Are you understanding? So if it is 1.5, I may be resistant. That's what she basically mentioned in that paragraph. That if it is 1.5, there is a plus or minus 1 over there. Okay, and that is why I will not give vancomycin at all if it comes to a 1.5 MIC, though it is resistant, though it is sensitive. MIC less than 2 is sensitive. It will show S. But the value MIC will be 1.5. If the value MIC is 1.5, I will not give vancomycin because this phenomenon of MIC creep and this plus or minus 1, which we are talking about, can hinder my treatment and effectivity of my drug. Okay, so VISA and VRSA. If you get VISA or VRSA, what would be the next thing that you would do? I just change the antibiotic to another class. I'd not even look at vancomycin here. Probably just change the antibiotic to another class because it can be quite disastrous.
So is there a genotypic test?
Yeah, there is. It's not, but not available freely. This will be phenotypic very often. When you do MIC, that's why you do MIC, no? You're doing MIC, it's a microbial dilution. With MIC, you're getting the MIC. With MIC, you're seeing that this is what is happening. It's a phenotypic test. You will also see sometimes in this vancomycin resistant. You will see that VRSA. That's VRSA. VRSA comes, it's going to be very, very disastrous because of the fact that at this stage you have to do extreme contact precautions. Extreme contact precautions. MRSA itself is contact precautions. VRSA becomes extreme contact precautions because you really are in a very bad spectrum. I mean the bacteria is really, really bad.
Did India also have?
Yeah, we had last time we reported one.
Yeah, it was-
Last time we reported one from our hospital. We had one year before last. We had one VRSA which we actually reported. We have to report these things. When it comes, no, we report that this is what we got. It's quite disastrous. It can be, it's like what I have used. I am not using now. Are you understanding the issue? I was using vancomycin right, left, center when I was in critical care, pass of critical care when I was maybe 4 years into y'all. I was using it. You all are doing a residency. After residency, 4 years also I used vancomycin. 4-5 years I used it. Vancomycin, 1 gram TD, every patient 2 gram TD. We should do that. Now I'm hardly using vancomycin. And I think the only indication that I have for vancomycin nowadays is infective endocarditis usually, for me. Because that is still the drug of choice for IE. Yeah? Any other questions?
So then treatment will be linezolid.
For these cases, yes. Any of the other drugs, depending on what it is. So if you have visa in the lung, I would probably use linezolid. If you have visa or VRSA in the urinary tract, I would probably use teicoplanin. If it is visa or visa with the presence of bacteremia, I would use daptomycin. It depends on where you are. So now you know the various drugs I have and the broad areas where I would be using it. Where I would be using for the lung, what I'll be using for the broad areas you have, the various options that I have. You have to look at the options and then decide what you want to do. You understand? So now you have a broad idea of how to treat these patients, and that is enough. For treatment wise, that is enough.
So, neuro we cannot consider.
It is gram negative. So when it comes to beta-lactam antibiotics, what did I say? When it comes to beta-lactam antibiotics, it is the cephalosporin, the cephalosporins for MRSA that works, and anti-penicillin, anti-staphylococcal penicillins that will work. Meropenem is not a great drug in these cases because it's usually a target for gram-negative organisms. When you have better drugs, why would you use meropenem? Gram-negative and gram-positive, divided like this. The gram-positive are these ones, gram-negative comes to all the rest.
Sure, and also some screen, like shore score.
Sorry?
Some
That will come when you come to pneumonia. When you come to, by the way, I didn't touch upon something very important that you should know as a practicing doctor as well as an exam going person. So when you have bacteremia that is positive, when you have blood culture that is positive, the first step to you would be actually to figure out whether this patient is a likelihood of infective endocarditis. We should discuss, no? Infective endocarditis. Take the phone, okay? Say in the lecture. When we say infective endocarditis, the complete treatment changes. We said that. So it is important for you to predict infective endocarditis. You can't wait for 5 days. You understand? Because what is going to happen usually, you have blood culture positive, wait for 5 days because that's what we require for transesophageal echo. Right? You wait for 5 days for transesophageal. But you should be able to predict it, no? Because I have to change it. I have to change this. The treatment for transesophageal is completely different as compared to this one. So I would have started this patient on Vanco. Whether to add Genta and rifampicin is a big question, isn't it? For that is a score that comes in. And the score that we use in this place is Versta score. It's called VIRST score. Versta score. There are 2-3 scores of which one is Versta and the other is Predict. Predict score. Okay, you have a score called as Versta score. So any patient who comes gram-positive bacteremia, especially Staph aureus or MRSA, you put it into the Versta score. The Versta score actually tells it's exactly what we look at when you look at complicated bacteremia. Is there vertebral osteomyelitis? Is there septic shock? Is there the presence of chronic meningitis? Is there presence of meningitis? You know, these are the things. Is there a prosthetic valve in place? These are the things that come together. You understand? So Versta score, can you open Versta score? Versta score in MD Calc or somewhere. Versta score. It is basically the same thing that is defined as complicated bacteremia. When you say it is metastatic, there is septic shock, there is the presence of in devices and things like that. VIRSTA. Can you read it out? And score more than 3 would actually tell you that this patient will require treatment for infective endocarditis even before the treatment, even before diagnosis. So let's read it out. Number 1 point.
Cerebral or peripheral emboli,
Yeah, peripheral emboli, that is metastatic. Peripheral emboli, cerebral emboli. Meningitis,
permanent intercardiac device or previous IE,
device,
pre-existing native valve, intravenous drug use, persistent bacteremia,
that is 3 days later, and
vertebral osteomyelitis,
vertebral osteomyelitis,
community or non-nosocomial healthcare associated acquisition,
healthcare associated acquisition,
and severe sepsis or shock,
Severe sepsis or shock.
or CRP more than 1.
and CRP more than 190. So these are the things that you look at when you see bacteremia. You look at that. If the score is more than 3, each of them has got a number, different number. Physically and mentally difficult to remember those numbers. 3, 2, 1, 2 is all different numbers. So it's better to actually just open up the MD Calc and probably or any of your QM Calc or anything. Put the numbers in place, and if it's more than 3, you will probably look at infective endocarditis protocol. So in simple words, any patient in septic shock with an IV line, with the central venous catheter, would be actually high score, would be 4. It would be actually a high score, it would be with high score. And that is the reason that you probably will need these patients to be on combination therapy of infective and quickly do a transesophageal so that I can get off all these toxic drugs. I want to cut off the rifampicin, I want to cut off this gentamicin, I want to cut it off. So quickly get a transesophageal or at least a transthoracic, very good window to see whether there is infective endocarditis at 5th day so I can switch off the drugs. Clear? Clear? So we can stop this now. Any questions further? Any questions?